The video series Glycemic Control Oral Agents was developed by the Georgia and Oklahoma Academies of Family Physicians as part of the Go Diabetes Initiative. The Glycemic Control Oral Agent series consists of 6 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for your participation in this online activity and hope that it serves as a valuable educational tool.
The one thing that I think is worth mentioning, although we do spend an inordinate amount of time on glycemic control, we talked about the first lecture that I gave, we talked about how glycemic control is not the end all, okay? Blood pressure control in type 2 diabetes you get huge bang for your buck. Cholesterol control in type 2 diabetes, Dustin will show you in a little while the results of primary prevention and secondary prevention in those patients with that. And so, but having said that, the thing that is hardest to achieve, it's not that hard to achieve blood pressure control in diabetics if you have a compliant patient and you have a knowledgeable clinician. But glycemic control is hard because you're dealing with a pancreas that's failing over time. And for that reason, we end up spending more time just because it's the harder thing among those other two pegs of that stool for the patient to achieve. So, here we go. Glycemic control, basically pills and GLP-1 based therapies. I want to just for a second, I want you to just review metabolism and what happens when you think about somebody in a fed state and somebody in a fasting state. When somebody's fed, it's like we all are right now, whenever you've eaten some carbohydrate, your insulin levels go up, your glucagon levels go down, your incretins, which include GLP-1 and a few other things, also go up. And those are released from the small intestine. In a fasting state, and basically what you're trying to do is store the food that you've eaten whenever you're in a fed state. In a fasting state, you're trying to release that food that you've eaten. And so because of that, your insulin levels go down, your glucagon levels go up, your incretin levels go down as well. This is a schematic for those of you who like to learn from these types of things with all the big players when it comes to glycemia. First of all, we have the stomach. Over here we've got small intestine. We've got fat and muscle cells, which are responsive to insulin as far as shuttling glucose from the blood into those where you can store it. You have the pancreas, of course, which makes insulin. It also makes another cell from another hormone from beta cells called amylin, which we'll talk a little bit about. And then you have something that's underappreciated, but the liver, the big producer of glucose via gluconeogenesis. And then the other thing that we don't talk about, maybe the biggest actor of all, is the brain. What tells us to eat, tells us you're hungry, it's time to eat, that kind of thing. So normally in a fed state, before you eat, your blood sugar is going to be in that 60 to 90 range. That's normal. So whenever one does eat, your blood sugar will go up, and your blood sugar goes up to 90 to 140 normally. And then what happens? You have incretins, which are released from the small intestine. And those send signals to the pancreas, to the beta cell, to, hey, make some insulin. It also sends a signal to the brain. It says, hey, you know what? You just ate. You can stop eating. You're full. And so the diabetic patient who says, you're kind of shaking your finger at them, why do you always overeat? It's not just lack of self-control and discipline. There's a hormonal reason for that. And the other place that incretins work is on the stomach. They slow gastric emptying. So these people feel full because their stomach is full longer, okay? And so those are the big things that happen. Now, the pancreas also, of course, releases insulin in response to insulin. Insulin shuttles glucose from blood into fat and muscle tissue. Now, in amylin, which is the other beta cell hormone besides insulin, I actually took an injection of that a little bit ago. Tells your brain, hey, you can stop eating, you're full. And but what happens in diabetes is all these things are, for lack of a better term, out of whack. And you end up with hyperglycemia. Your incretins don't work. Your pancreas doesn't make glucose appropriately in response to a glucose load. Gluconeogenesis is never turned off whenever you're eating. And so all these things don't work well, and you result in diabetes, essentially. And this is just a slide that shows where all of these different therapies are targeted. And we're going to go through the majority of these. We're going to talk about insulin, sulfonylureas, incretins. We're going to talk about TZDs, the other things, portion control, dietary composition, and alpha-glucosidase. And we're going to talk about all these things, but this is just, for those of you who are more schematically oriented, hopefully that's helpful. Question. Do you currently feel comfortable managing patients on oral agents? Whenever I was in training residents, the thing that I noticed is like, okay, you diagnose somebody with diabetes, and you tell the residents, like, okay, well, what do I do? Well, we're going to start them on a medicine for this, and we're going to educate them on all this. I'm like, well, what medicine should I start? Well, there's name one out of 6 or 7 that's possible that you could start. But let's see let's see, Sue, what do I do? Click. All right, so 72% of you feel comfortable, while 28% of you don't. Well, hopefully, at the end of this lecture, that number will be more like the 28% more will feel comfortable, and that 72% may feel even more comfortable. General rules. So these are the things that you need to keep in mind. Number one, don't forget lifestyle changes. We talked earlier about how MNT, medical nutrition therapy, lowers A1C in a patient who actually does it. And a type 2 diabetic who actually does it, it'll lower their A1C at least a percentage point. Okay, if you can get somebody to eat less, to exercise 30 minutes 4 or 5 times a week. And then the next thing to think about is what's actually going on with the patient. Does the patient show signs of being catabolic? Okay, by catabolic, are they losing weight? Do they have polyphagia? Do they have polyuria? Do they have polydipsia? Those are patients that need to be started on insulin. And then if they do have insulin resistance, which is the majority of patients, then think about attacking that via medicines like metformin, perhaps a TZD or something along that line. And then also realize that you're going to have to add therapy. So a type 2 diabetic who's controlled now, it will require additional therapies as the patient progresses with the disease. And when I say normalize the fasting glucose, and the reason is that you're going to normalize the fasting glucose is that a large majority of your patients, if you get their fasting glucose in that 90 to 130 range, their A1Cs will be about 7, okay? There's still some people who won't. And so the next question is, well, I've got my, my fasting blood sugars between 90 and 130. When should I really worry about those postprandial blood sugars? And the answer to that is when you've normalized the fasting glucose, you've got them at 90 to 130, and their A1Cs are still above 7. Then you clearly have a problem with postprandial issues, and you need to address that. Whenever you tell your patients what are your goals, what you're going to tell them, use over here where it says verbal. I want your blood sugars when you wake up and before you eat to be about 100. 2 hours after you eat, I want your blood sugars to be about 200, and I want your A1C to be less than 7. So those are the 3 numbers that you're going to tell people consistently. And the reason that these numbers are given here is because if you're meeting those targets, if your fastings and your preprandials are less than 100 and your postprandials are less than 200, then you're going to have an A1C of 7 or less, okay? This is a slide that I think is interesting that shows the role of fasting glucose and postprandial glucose. If you have somebody who has horrible glycemic control, in other words, an A1C in the 10+ range, the majority of what you're dealing with there is a fasting blood sugar issue. And so you put those people on a basal insulin plus maybe metformin, and you might have a chance of getting them down. Now, a good percentage of those people will get A1Cs eventually down to around 7. But there are some patients that you can't, and the reason for that, you'll put them on a basal insulin and you cannot get their A1C below 7.5, okay? The reason for that is that in those patients, the lower your A1C gets, the more of a role you're dealing with postprandial blood sugars. So 70% of your A1C as you get down lower is because of postprandial issues and not because of fasting issues.